as the Assurance and Risk Committee for University Hospitals Liverpool Group. Thank you for being here. Particularly welcome James Thompson, Tom Farrow to this meeting. Good to see everybody. We have a lot of business to crunch through today. Apologies from Peter Turkington, who's away, and welcome to Shahida, who's here to represent Peter and to steer us through the Aintree business. We are Cora in our meeting. We've dealt up until since we came together as the group board covering both Loughton and the Women's. We have dealt with the substance of our risk and assurance agenda in the board meetings. And what we found in the last few meetings is that we've become crowded out because of the weight and substance and the need for careful consideration of the issues therein. We've crowded out the space at the board that we need for, it's not just a more strategic perspective, but it's a more rounded whole picture of where we're at, where we've been, where we need to go to. So we've now re-established the Assurance and Risk Committee, which was part of our governance structure when we met as the board of Loughton alone. That gives us an opportunity today. This is to get deeper into some of the detail where we need to. There will still be escalation of matters to be considered in the full board setting, and we'll work through that as we go through the agenda. So the only apologies, Peter, we've just got a couple of matters, James, that you might want to raise as urgent matter arising before I get into the agenda.
Yeah, thank you, Chair. So just wanted to raise the issue that many of you will have seen on the news last night, that the Lucy Letby case, there has been obviously further action around arrests of the leadership team from the Council of Chester, but more importantly for our discussions, that the case is now being presented to the CPS for some cases that span Council of Chester and Liverpool Women's Hospital. So obviously that's something that will directly affect our board. Now it's something we were aware of and knew could be a possibility. So at the moment we're taking the very clear advice of the police and the CPS, which is no comment on these issues. From a patient and family perspective, everybody is very well aware through the previous investigations. It's very simple for us to make contact with anybody who has any concerns, who might call into Liverpool Women's on that basis. So all of that's in hand. What we did want to do was at the private session of the board next week, just update the board on where we are around the legal aspects of that. But for now, it was just to sort of raise the fact that any immediate sort of patient family issues are well handled, and we've followed the guidance that's been given by the police and CPS throughout. So we'll talk more about it in the private session of the board next week. So non-execs and execs have got an opportunity to ask any questions about the future direction that this might take now and what that might mean for both the organisation and for us as a board. So we'll discuss that further next Thursday.
Thank you, James. Okay, let's move on. We start with terms of reference and also the cycle of business for us meeting in this committee. Daniel, can you take us on to this, please?
Yeah, thank you, Chair. As you've just set out, you've explained very clearly to members the purpose of this new committee. In terms of the terms of reference, just wanted to highlight a couple of things. There's an error in just the terms of reference that was sent. Whilst we did include the chair, we excluded all of the other NEDs from the membership of this committee, and obviously we've agreed that this committee will include all non-executive members as well. So that is an addition that we will add in. Just wanted to highlight, obviously, as it includes all board members, I wanted to refer towards the back of the terms of reference. So from this committee, we will be escalating, making sure from a public point of view that any significant risks, i.e. those risks that have a score of 12 or more, will be escalated to the board. But together with where there are issues that will affect the delivery of the trust's delivery of its plan, constitutional standards or strategic risks, we may need to specifically refer those and escalate those to the board so that the board can have oversight of the mitigating actions and ensure that they are delivered okay. So happy to take any other questions in relation to the terms of reference just before I move on to the cycle of business.
Thank you. Any points, concerns? Go Jackie first, please.
It's just on the first page. It talks about reviewing and improving the proposed 23-24 rather than 25-26 terms of reference and cycle of business.
And Sue, please.
Yes, I just wanted to reference the interaction between the Audit Committee and this committee, and just wanted to sort of make the point that I'll be meeting with Daniel just to ensure that the responsibilities are very clear and we understand if there's any sort of duplication, just as it's a new committee and Chris does also sit with the Audit Committee. So I will meet with Daniel offline just to clarify that and ensure that the Audit Committee discharges its terms of reference in line with anything that this committee is doing. Thank you.
David.
Yeah, thank you. And this, apologies if this seems a bit pedantic, but at point 24 in the terms of reference, it says very definitively that agendas and papers will be circulated 5 working days in advance of the meeting. I just think I'd be more comfortable if we gave ourselves a little wiggle room there, because I'd hate to have a piece of business that we couldn't talk about because the papers came out late for very good reasons. So I just think that if they were on that line, that we would endeavour to circulate working papers five working days in advance, then I'd be more comfortable with that, Chair.
Yeah, okay, I agree that change. We're good at endeavouring.
Yeah, so just in terms very quickly, Chair, I mean, we do try and obviously with all of our committees, including the Board of Directors, we should aim to get the papers out 5 working days to give all members of the committee opportunities to read over 300 pages, as you said. There will be occasions, as we all accept, that there may be papers that need to come at the last minute, but we should get the main pack out 5 days in advance, i.e. Usually on the Friday when this meeting's and on Thursday. My view is, whilst we do endeavour, we should get the majority of papers out and keep us to that focus to give people sufficient time. In relation to the Audit Committee, the main role of the Audit Committee is to make sure the systems and processes are in place, and I'll speak to both Sue and David as the respective chairs of the Audit Committee, just to make sure that we've got it clear in the Audit Committee cycle of business about roles, responsibilities and purpose of how this connects.
Thank you. The cycle of business then? Yeah,
so obviously what we've done, we've tried to map across, and we've changed the cycle of business for the Board of Directors as well, just to make sure that there's connectivity. This is the cycle of business that we've used. The only changes that I wanted to raise in addition, because we've got a little bit of clarity around the CNST maternity incentive scheme and the perinatal quality surveillance tools. They do not require full approval by the Board of Directors. They can be delegated to a committee. They are on the agenda today, and we wish to add them to the cycle of business for the Assurance and Risk Committee. And when the Assurance and Risk Committee does a assurance report to the board, we will clarify where they have been approved each month. So that was the only change to the cycle of business that we wish to make to those put in front of you.
Any concerns, points, please? David, okay.
Yes, thank you. It seems a very comprehensive list, and I had to get a magnifying glass out to read all the details. So well done. The only thing that I could think of that might be missed is we've had conversations in past years about reference costs, and how our reference costs are reducing compared to other organisations. And as I understand it, Rob's used that information very powerfully to demonstrate to others that our financial position is improving. If we had a finance committee, I think those reference costs would go through the finance committee when they were finalised before submission. And I just wondered if we could add those to the list, because I know they're a bit geeky, but they have been proved to be very powerful when we've seen them in the past.
James?
Yeah, I agree. Sorry, I can see Rob's put his hand up, but I agree. One of the benefits of having this committee in place is it just gives us that bit more headroom to have more of a focus on some of the detail, as David said at the outset. So this would seem a good place for us to bring things like sort of reference costs on an annual basis, but also updates around things like some of the model hospital data as we get it. There's also a new performance framework segmentation for all trusts, which we've just got letters about last night, and there's workshops on next week. And effectively, trust segmentation will now be based on a formula of both performance and finance metrics. So that again feels like a good place in this meeting for us to sort of take a look at how that's evolving and changing as well. So it just gives us that bit more headroom than we had perhaps in the board meeting where we were trying to do the strategic agenda as well. So yeah, very happy with that, David.
Thank you.
Thank you, Rob.
Yeah, thanks, David. Thanks, James. Yeah, just to note that we've got a paper on the board for next week, because the board has to sign off the process for the reference costs. So they're actually getting submitted in the next days. So the process we're going to describe, and then similarly the board has to see the results, which will bring back probably around November when they're published. So at the moment that's going into board, but if it comes here for further scrutiny, I think that's a good thing as well.
Yeah.
Okay. Agreed. Thank you. Any other points on cycle of business? Okay. That's good. Let's move into the substance of the agenda of the risks, and we start with the group risks. James, I don't know how we...
Yeah, I'll walk through these. So the corporate services risks, as we've always referenced, the hospital sites will talk about the risks specific to them, but corporate risks that sit across the organisation we bring through in this report. That now comes here. So you'll be familiar with these because several of them were reported to the board last time. The two financial services risks, so these are risks at 12 and above that are the sort of focus of this committee. Cost improvement plan development and the financial balance, I would suggest we'll get into in much more detail as we go through the site reports and then into Rob's finance report later. But obviously the key challenges for us there around the identification of the full CIP plan, and then the challenge basically around things like NC2R. So there'll be, I think, some good updates from sites and Rob later on that. The corporate ops risk around the ED performance is in there as a 12. You can see in the performance packs that for type 1 we're at 59%. We need to get to 78. I think this is an area that we have some confidence about moving toward this year, but I would suspect we would want to have a bit more of a deeper dive into particularly the 4-hour aspect of this at a future meeting. I think today we'll probably concentrate a little bit more on non-criteria to reside, which is the underlying issue that's driving the problem. So that will come out in the site reports, and then perhaps at the next one of these we might want to do a bit more of a deeper look at the 4 hours. There's a people and OD risk, which is around the vacancy restrictions, and this is something that's hitting us across the organisation because we're now in our second year of vacancy controls and freezes around administrative posts. You can see in the risk and the articulation of the risk statement that this is being carefully managed, QIAs, EIAs. The solution to this is obviously getting the corporate service target operating models underway as soon as possible, because what that's going to do is that's going to allow us to see that same risk across the 5 organisations. And then if there are immediate issues and risks, i.e., let's just take people in OD as the example, if there were insufficient people across the 5 organisations and that risk was collective, we could address that now rather than having to wait for the target operating model to be derived. In another area, if there were significant risks on one site but not in the other 4, we can look to share resources until the target operating model is carried out. I missed, sorry, a page on there, which was just around the mental health aspects of the corporate nursing safeguarding risk. Pleased to say that joint working group now is getting some traction. It feels like there's a much better grip on the situation. And I know that David, in his update on this, has suggested that it's likely that this risk would be reviewed in July and potentially reduced because things have moved forward. So that's very positive. And then you can see some corporate operations risks around the diagnostic standards and the issues that are particularly challenging there, echocardiography in particular. And that's a case of need has now been approved around that. So we expect that to improve, but it's still a challenge. And on the elective recovery, risks around people waiting no longer than 18 weeks. These are the new standards. All of these are in the IPR and you can see where we are on them. I think at the moment on the elective and cancer side of things, we've got more assurance that we're moving in the right direction, but there's still challenges around long waiters on the different sites. So I would think we'd have probably more confidence on the elective side than we have perhaps on the urgent care side, as has been the norm for the last couple of years. But it's still a 12 at the moment until those residual plans are delivered. So in relation to all of those risks, I would suggest, Chair, if the group are happy, that the financial risk probably is something we'll get into in the reports that come next. If there are questions on the corporate operations stuff, then Beth or myself or sites could take them now, or on the mental health risks, it would be David, and on the people in OD risk, it would be Heather or the individual sites. But they're the key corporate risks that we're managing at the moment.
Okay, thank you, James. All right, so you track back over previous board meetings, the corporate risk list is getting longer in terms of what's scoring at 12 and above, reflects the very challenging context in which we and every other NHS provider is operating at the moment. But means we need to double down our focus, particularly as our reports today take us to the end of month 2. We're effectively now into the second quarter of the year. The weeks we're running through quite quickly. It's important we understand where we are and what the plans for improvement are as we go forward. And we still have the IPR, which tells us where we've been and where we're getting to. Some of the finance charts project where we're going to go forward on some of the measures, but we still need to try and find a way of getting that sense of how we model what we expect to happen to track an improvement going forward, so that we can use that as the frame.
I would suggest by next month, if we focus in on some of the ED stuff, again, I won't jump ahead of what you're going to be told by sites, but there's been some fairly significant improvements in quite a bit of the challenges around the urgent and emergency care, and some good movement in the things that we needed to deliver to get us to a better place around TOC, around NMC2R, and around beds as well. So next month would be a really good opportunity, or the next meeting would be a good opportunity, I think, to do a bit of a deep dive in that and then make some predictions about where we think we could get to. Yeah.
Matt, next, please.
Thanks, James. I think it's interesting that we've got quite a good level of retention, staff retention, quite consistent, and it'd be interesting to see how the vacancy control issue, which we know is system-wide, will have an impact on that. Will it increase our retention rates, because we know people will struggle to get jobs elsewhere in other NHS organisations? And just on the ED bit, I think it's probably worth reflecting, isn't it? Despite the challenges, the Friends and Family Test survey is really strong, isn't it? So really good feedback from our patients around their experiences in ED.
Yeah, I think so. On the ED bit, we'll certainly, again, I suspect, pick this up in the site reports. But my view of where we are on ED is we're seeing some fairly significant improvements, driven by not only the CQC's view of quality and safety in the departments, which is massively improved. Friends and Family Test is massively improved. The flow is better, but we still have this issue of we should really be getting quite a lot of the non-admitted patients through the front door in less than 4 hours, and we're not where we need to be on that. So when we do our deep dive into that next time, it might be sensible for us to, instead of sort of saying, well, the 4-hour target needs to be 78% by the end of the year and just drawing a line from here to there, I think we really might want to start to look at some of the metrics around what we're doing around non-admitted patients, because those that go home really should be seen within that 4-hour target more often than not. So that's something again that Nat and Peter are already discussing as part of the programme that they're working on. On the retention stuff, I took a look the other day at some of the IPRs across organisations. Everybody's seeing a massive improvement in retention, which you would assume is a good thing until you realise everybody's got vacancy controls in and nobody's advertising any jobs. So there is that risk here of false sense of assurance around retention, and actually we're retaining people who are frustrated and finding things difficult, but there's just nowhere for them to go. So we have to sort of keep that in mind, I think, about the retention numbers at the moment.
Sue, next, please.
Thank you, David. Just wondered, in terms of corporate risks, you've highlighted all the corporate risks that currently sit above 12. Are there any emerging risks which are getting quite close to 12 that we should be aware of?
Those will sit on our risk register that we go through at the senior management board, Sue. So we'll take a look at everything that sits between that sort of 9 and 12 level. If there was anything we thought was significantly, i.e. we know that's going to land as a 12 next month, we bring it into this report. But at the moment, these are the only ones that we think are likely to be 12 and above as we sit here now. We look through that senior management board with all of the sites together in the corporate teams.
Great, thank you.
Mike, please.
Thank you. Thanks, James. It's really helpful. There's one question of clarification or one question around assurance, please. The clarification is on theatre session utilisation, which I think there's different ways of counting. Are we happy that the 81% and the 91% target are consistent figures, that we recognise the 91% target in the way that we would count? And then the two pieces of assurance are around e-news, which I absolutely take the improvement, but it's never hit 95%. And the pressure ulcers and falls, which we report as within expected levels of variation. But that presupposes that performance level is okay. So just a couple of comments on those, please. Thank you.
Sure. I'll bring colleagues in on this. I don't know, on theatre utilisation, Nat, did you want to come in on that one, or was that?
Yeah, all of them if you want me to. So theatre utilisation. So Mike, the session utilisation is how many of the sessions that we could have operated in did we actually use? Obviously, there was a half term in May, so that will have impacted across. So you'll see in the Royal it was 80% because there will have been higher annual leave, but we wouldn't have staffed to those sessions. So it's not a lost activity to staffing. So that's the theatre sessional utilisation. I'm happy we've got the processes, the tracking, and that's standardised across the site. So happy with the reporting of that. The e-news, you'll see in the breakdown, the IPRs, the main issue is at the Royal. And you'll see in my report that they have identified there are some areas included. We're just sorting that now with data to be above.
No, sorry, you sound disappeared when after e-news, the issues at the Royal.
Oh, sorry. So you'll see in my report we picked up on that. So we are expecting improvements at the Royal. There's a number of areas that are feeding through on the data at the minute which should be excluded from the e-news for some of the assessment areas. So they're just rectifying that, and then we expect to be compliant, and that should move Lough's overall e-news compliance up. And the pressure ulcers, again, we've looked at this, and I think David will want to come in because we know it's a specific issue at Aintree that David and Pete were leading on.
David, do you want to come on this, please?
Thank you very much. So the pressure ulcers, yes, it remains stubbornly within that normal variation, and we're not seeing the reduction as we would want. As Nat said, that this was a particular series of cases over in Aintree, and it was around just a few number of patients who had very particular circumstances. Some of them were end of life. And it was a decision by the family around not moving those patients, but obviously we still need to record any harms to those people. And then there were some other particular issues. They've been reported previously to board. I really want to give us some assurance that this remains a focus around how we can continue to reduce tissue damage to our patients. What we have seen is a very small number of patients, because of the ventilation devices that they've been using. They've had some tissue damage, and we're working with the manufacturers to see are there any national issues that are being identified, but also are there any solutions that other people are using that we can import into our organisation.
Thank you. On the e-news and on the VTE risk assessment measures, I mean, we're exceeding the 95% on VTE, which is very good. It's a question, Jim, really, in that, so we say, or someone sets a target, says there should be 95, presumably. Is that, why isn't it 100? It's a simple way of saying the question. Why wouldn't we just do that for everybody? Is it because it's inappropriate for some people, or that we think 95 out of every 100's the sort of best we can do?
It's a question that comes around, Chair, isn't it? In the VTE assessment piece, there are I think we find there are exceptions because there are patients coming and going in the system. There are day case patients, there are patients who report and cancel and so forth. So there's a kind of practical administrative reason why we've gone for 95%. It was also a national target. So what we're trying to do was to be compliant with that. And then I think when we look, and it comes up in the sepsis issue as well, we do sometimes find that there are simply data recording issues, and we go back and find that actually if we do a manual search, these things did happen, but they didn't get recorded. So I think, to be candid, it's a pragmatic kind of figure that's very good, but leaves a little bit of room for error.
Okay. David, please.
Yes, thank you. I just wonder if we could go back to theatre productivity. I hear what Nat said, but I think I need to understand it better then, because 65% touch time at Broad Green, 76% touch time at Aintree, it feels as though there are some missed productivity opportunities there, and that we're not using staff theatres as we would like to.
Could I just come back on that, Chair? So I think we just need to clear down. Sorry, my response to Mike was on the session utilisation, which is of the total number of theatre lists, how many did we use that we could use? What you're referring to is when we do a theatre list, have we put enough cases on that list to make sure we've maximised? So that element, you're absolutely right. At Broad Green, there is an issue with orthopaedics, and that is being addressed through the Transformation Board. So when we get the Transformation Board updates, Aintree have a specific project on orthopaedic and productivity in there, because we've identified we absolutely could be making more and getting more cases through the orthopaedic theatres. So that's the difference in the metrics. But where we've identified there are productivity gains to be made, they're included in our site transformation plans for this year.
Thank you.
Thank you. Okay, let's move on to the site reports then, because we've drifted into some of the site specific issues. When we've gone through all the sites, if there are whole organisation or broader issues that we want to come back to in the IPR, we can. Let's move on, and we start with Royal Management Board key risks. Natalie.
Thank you. So just pick up, there was two urgent issues raised in the HMB, so just to update on those. One was around, you will see in the IPR we had an increase in CDT cases at the Royal again in month. We had 10 cases, and at the same time we were getting escalations around the cleaning delays at the Royal, which were causing impacts on the flow from the emergency department. Part of this we think was driven around vacancy controls and the lack of people to pick up some of the bank shifts to support the domestic service. Following HMB, Rob and I have reviewed and we've linked with the ICB, and the vacancies have been released. So we're expecting that to improve now. In the meantime, we are supporting some HCAs who are willing to pick up bank shifts and support the domestic service with some training, so we can have some short-term cover plans. So I would hope by the time we come back next month, I can report an improved position on that. The other issue that was raised in the meeting, again, directly related to some of the changes in the bank rates, was a lack of uptake of critical care bank shifts, which did result in one patient cancellation on the day of the HMB. I would report though that week we were implementing the EPR into critical care, so it was a significant week for critical care. Since that, we've had full uptake of shifts and we've had no further issues in critical care. We also have 7 vacancies and they are planning to fully recruit to those vacancies next week. They're interviewing. So again, I think that is under control and we're just keeping a close watch on that. But I'm not concerned that we've got an ongoing issue now in critical care. If I just talk through the decisions made and then I'll cover performance and risk. So that we did receive a business case to the Hostel Management Board, which has been in train for quite a long time, which was around urology. So since COVID, we've been supporting the increased urology demand with a significant amount of insourcing. So we use a company 18 weeks to help us support our elective activity. And the business case was to enable us to deliver the increased activity levels, but to do it through increasing our substantive staffing and enable us to reduce our current expenditure run rate by approximately £430,000. It says in the report that was to go to execs, and we actually had execs this week, and that business case has been supported. So through the future Transformation Board updates, you will see we will track the implementation of the urology business case with the anticipation that although we will see an increased whole-time equivalent as we take on these staff, we should monitor now, we should remove insourcing for urology and reduce the premium costs related to delivering the urology activity. And that directly relates to risk 7096, which has been on our risk register at a 12 and a number of months. As we start to see that recruitment take place and we hit those metrics, I will be de-escalating that risk. So, sorry, Jeffrey, do you want to come in on that point before I move on to the risks and performance?
Thanks. It's the urology, really. Is that linked to the ketamine challenge? The issue, because I know MWL have had to increase the number of urologists. On the news this morning, Alder Hey now set up a separate unit for young people suffering with ketamine. I know in St Helens it's a huge issue.
Not really. The issue we've got is that demand for urology generally has increased by 15% over the last 3 years, and we haven't increased the workforce. So really, it's just the increasing, and our cancer pressures, the biggest cancer pressures generally for us at Luft at the minute are in urology. So it's really just baselining to make sure our staffing model meets demand. What this case will do is we have a facility on the Aintree site. It was an old ward, Ward 13. That is not currently fully staffed. This will enable us to move a lot of urology procedures out of theatres and put them into that facility on the Aintree site and do them as outpatient procedures. So it also fits with the national productivity ask around right procedure, right place.
Thanks, Natalie.
Tom, did you want to come on this?
Not on this point, David.
Have you another point you want to come on?
Well, I just wanted to ask about the Never event in the Royal in May. I've forgotten
Yes,
what that was.
I'll just come to that in the IPR. So we have got one Never event reported. This was on the cardiology unit, and this was the administration medication. There was no harm to the patient. I'll just pause in case Jim or David want to come in on more detail on it, but it was on the ACU, Tom, at the Royal.
And Jim?
I'm happy to, Chair, if that's helpful. We have reported this before. It was a patient who was being managed at end of life, had a history of opioid dependence, and was given some subcutaneous opioid, but actually the medication should have been given orally. So it was a Never event because it was the wrong site, but there was no harm to the patient.
Thank you.
Thanks.
That was the one we heard about before. That's what I wasn't clear on. Thank you.
Thank you. Okay, so just moving then on to performance and risk. So I'll just try and split it into sections. So as James said, if I start on urgent and emergency care, and in Pete's absence, I'll just cover where we are for the whole of Royal and Aintree and Broad Green. So NMT2R, if we touch on that, we have seen some significant improvements in our not meeting criteria to reside. At the minute, we're averaging about 320 patients on our not meeting criteria to reside totals. That has decreased from where we were, which was around 400. So we've seen a significant benefit in that reduction. If we look at our longest length of stay patients, so we were averaging about 67 patients who had a length of stay of over 100 days. That's down to 36 today. And over 60 days, we're up around 170, and that's down to around 105. So we've seen some of those longest length stay patients getting now complex discharge plans in place and being supported to more suitable placements. What that has enabled us to do, so from a Royal perspective, we have de-escalated and decreased the ED corridor, which has enabled us to reduce the number of registered nurses within the ED on the daily rosters. And we are just in the process today of de-escalating. We have an area on one of our wards where we place medical outliers, and we are just de-escalating that area now. So by the weekend, we will have closed those beds to release further savings. From a Royal and Broad Green perspective, the plan will be then to move on if we can get further NMC2R reductions. We're at 17% at the minute at the Royal. Once we get that down to about 14, we will start de-escalating a medical ward. And in August, there are plans to also de-escalate a ward at Broad Green. From an Aintree perspective, they've seen significant capacity reduction. So they've closed over 100 beds since April. I know Shahida will cover some of the detail in her report, but we are massively reducing our bed base at the minute, and we are tracking that aligned to the not meeting criteria to reside reductions. Previously, we've talked about the Pathway 1 issue and the fact that that needs to be our primary focus now, and how we need an integrated discharge approach, which is integral to the transfer of care hub. So since the last meeting, we have now gained agreement between ourselves, Merseycare and the councils, and that is across Liverpool, Sefton and Knowsley Council, that we will create 2 transfer of care hubs, one based on the Royal site to manage the Royal and Broad Green, and one based on the Aintree site. We have a project team now in place, and we have a 6-week implementation plan to establish those at latest by the beginning of August. So I'm leading that programme, and we're meeting weekly and we're working through that. So next month I should be able to update on the plans of that, with the aim that that should bring down the time to discharge our Pathway 1 patients home. So just on the Royal metrics in the IPR, you'll see in May we maintained a 38-minute ambulance handover time. Currently that's now sat at 28 minutes, so we are keeping on with the good work around ambulance handover. We got 56% achievement of type 1 performance and 79% all types performance. So that has improved, and that is due to the focus on the non-admitted pathway. The bit that needs further focus at the Royal, and that there is now a weekly improvement plan in place, is around the 12 hours in department. So you'll see in May that was at 18%. We have seen improvements in June, but to get to the national ask of 10%, there's still quite a bit more work to do on the Royal. So that's where our Director of Ops is focusing the attention. From an elective perspective, really strong elective performance at the Royal. So we have no 65-week waits. And in the report, you can see against the 1% target for 52 weeks, we were at 1.08. As of today, we're at 1.03. So, and you can see the overall waiting list size is really reducing across the specialties. The one area I'd just draw attention to that was a risk was around Broad Green, and that was the dermatology service. So we'd seen a significant increase in 52-week waits. Now, that is because Broad Green is one of those services that has been reliant on WLIs and premium activity to maintain its service, and we had reduced those in line with the financial controls we've put in place. I've met with the team, and what we've agreed is we have agreed some short-term ACCs to support the service this month to make sure we keep that under control, whilst they have appointed a GP who is due to start, which will support activity moving forward. And we've got an advert out for a substantive nurse consultant and a candidate who has expressed an interest who we would be keen to employ. So we're just going to have to short-term support dermatology while we get that long-term staffing in place, but I'm confident we have got that under control and we'll be able to de-escalate that dermatology risk. So just moving on to the other items in the IPR, I think we've already touched on. I wanted to draw attention to e-news, that we will resolve that data issue, and then I expect that to be improved next month. And I know we just touched on VTE, but we had a discussion about this at HMB. If you look at the Royal report, it's consistently around 93 or 94%, so it's not quite meeting the target, and it hasn't been for a number of months. So our medical director is picking that up as a focus at Clinical Effectiveness Committee this month, and we're going to look at how we can get that above the 95% moving forward. And then just moving on then to Other risks. So on the risk register, we've got 17 risks currently scoring a 12 or above. There are 5 new risks in month. 4 of those are the new risks relating to CIP at a divisional level, which I'll come on to in a minute. And one of those relates to the dental hospital. So the new risk at the dental hospital is that the dental run one operating theatre. It's a standalone theatre over in the dental building. Due to some sickness they have had both in anaesthetics and in the dental nurse staffing, they are struggling to run all their theatre lists. So they escalated that risk, and we're looking at support plans utilising theatre staffing and anaesthetists from over the Royal to try and maintain that dental activity. There are 2 risks that have increased in month to a score of 12. So one is the dermatology risk I've just mentioned, but I expect us to be able to decrease that next month with the controls we've now got in place. And the other is a risk escalated from St Paul's around proton beam therapy. This is a risk relating to equipment that is coming to end of life in the Clatterbridge Centre. This is a service that is only provided. I understand we're the only centre nationally that does this, and the replacement of this equipment will be a multi-million-pound programme that will need to take place. St Paul's have escalated this risk, and I've got a meeting in the diary with Joan Spencer, because what I don't understand or I'm cited on yet is Clatterbridge's plans for this. So it may be once I've met with Joan we can de-escalate this risk quickly, but I'll have that meeting next week, and then I'll be able to update. So just moving on then to finances. We have reported at month 2 an adverse position of 2.1 million against our financial plan for the Royal and Broad Green. I suppose there's 3 main things I would update on in this. So 1.4 million of it relates to underachievement of CIP, and that is our critical issue at the Royal and Broad Green. 1 million relates to overspend due to providing WLIs and premium activity to deliver our income plan. We have had the budgets removed, so we no longer have the budget for this, which was previously funded in previous years. So it is showing as a cost pressure. But we have approved both now gastroenterology and urology business cases, which will reduce the run rate. So both those business cases, we expect to reduce the run rate by circa £1 million. They're being tracked through our transformation board, and we are on with recruitment to get those services in place. And the other cost pressure I just cite is the GP service we're providing in ED. So this is something we put in through winter to support the winter pressures, and is a cost pressure at the minute to the Royal each month. But we have now managed with the AIB to agree that this will be funded from month 3 onwards. So we expect that cost pressure to not be in place from June onwards. So just focusing on the main issue, which is CIP. At the minute, we have transacted 12.3 million. As of now, that's closer now to 13 million. That is all recurrent. So we've transacted 13 million recurrent, and we've got another 3 million of green schemes, which I will be expecting to transact. That gets us to about a 16 million achievement of CIP against the 34 million pound target. We have fully identified all schemes, but the main issue at the Royal is that about 12 million are still in red. We're working with the teams, and I'm chairing the meetings every 2 weeks to move those quickly through to amber. And I know when we come on to it with Rob, we'll talk through further actions we are taking, but the risk to the Royal's financial position is mainly that gap in the CIP and the pace at which we need to close it. The rest of the risks on the risk register have been there in previous months and have all got narrative against them. So I'll pause there, happy to take any questions, Chair, and assume we'll pick the finance up in more detail later on the agenda.
Yes, I'm sure. James.
Yeah, now the one thing that was really worrying me in the IPR is the cancer 2-week wait, because we've talked about it previously and the resolution of that. There was the breast issue, and then we thought it would get better after that. I suspect urology is part of it. But what's happening with that? Because that's now sort of plummeting to 30-odd%.
Yeah, so it is a combination against breast, urology and dermatology. I think the issue is, as you'll see though, I suppose the assurances were not plummeting on the faster diagnosis. So although the first appointment might not be within the 2 weeks, when they are attending, they're doing a one-stop clinic and they are getting their diagnosis within the 28 days. So it is that pressure on getting that first appointment within the 2 weeks still. So we're still using significant insourcing capacity for breast. That is still a significant issue for us.
So I suppose from a board perspective then, how can we be assured that, sorry, don't take this the wrong way, but how can we be assured that what you've just said is true? So for every one of those 40% or 30-odd% that aren't getting a 2-week appointment, how could we be assured that they're all getting a definitive diagnosis within the within the 28 days? Is there any way we can illustrate that somehow? Because that sounds like a good thing, but obviously, as you know, when we had press interest in the breast clinic issue, patients were saying, well, I've been told I've got to wait a month for a 2-week wait, when actually the totality of the pathway was still being delivered well within the national timeframe. How would we get better assurance that that's like for like?
Yeah, well, that's included in the IPR, isn't it? The faster diagnosis standard, which is the 28-day standard, which is at 76%. We internally track the time to first appointment, the time thing. So I've got that detail, which can be provided in more detail to the board if we want that.
I think, I know it's there. What I'm saying is, you've described that the problem on the 2-week wait is 3 specialties. The FDS is all the specialties. How would we know? So it might just be a one-off. Could you sort of give us something one-off, even if it's just verbally in your report next time that says,
that's fine.
If these 3 specialties that didn't meet 2 weeks, I can evidence that they all met 28-day.
Yeah, that's fine.
Yeah, that'd be helpful. Thank you.
Yeah, that's helpful. Thank you. Mike, please.
Thank you. Thanks, Nat. It's quite a general question. If it's too general, just say that's too general to answer. And it's a link between performance and finance. And you know that thing about get the performance right and the finance looks after itself. I know it's not quite that neat, but what you've reported is significant performance improvement in really fundamental areas, and that all good. But we're still not seeing the financial flow through from that. So my question is, what are the performance blockers that are leading to financial challenge? If we could get the performance right in area A, that we would really see a flow through in terms of finance. Does that make sense to the question?
Yeah. So
I'll come in first, Natalie.
So I just wanted to make a point on this issue, because I was just saying this to David ahead of time today. When we get into the discussion later on the money, we really need to be looking at the sort of relative performance in sort of normal circumstances versus this massive stretch that we've got this year. So what Nat was just describing there was effectively a, excuse me, pay under control, a million-ish pressure, because, you know, on the 31st of March, the ICB said we're not paying for lists that you deliver through waiting lists. So suddenly £1 million worth of budget gone. Well, actually £6 million worth of budget gone. And then you need to find a way to replace that. And obviously these business cases will do that. What I think we need to not miss is that what's just been described, I think, from what you said there, Nat, was almost probably a CIP in the region of 10-11% at the Royal, because of that waiting list reduction issue. And then almost nearly all recurrent delivery of about half of it. So we're talking about
15,
recurrent delivery
16.
of 5, sorry?
Yeah, about 16 million.
Yeah, so we're talking about, and what's your total target?
34.
Yeah, so about 50% delivery. So we're talking about 5.5% recurrent delivery, which is what that performance improvement is delivering. The problem is, in the way that we allocate the CIPs out, you sort of struggle to see where sites could get to 7, 8, 9, 10, 11% recurrent delivery. And this is where, when we go in later with Rob, we've got to find other ways now across the organisation of filling in that additional stretch 1 and 2, because it's realistically, we can see already, despite massive performance improvements, 100 beds out of the system, all the things we've struggled to do in previous years, we're actually in a better position than ever, i.e. significant percentages of recurrent delivery, but because of the 2 stretch targets that were dropped in, still not enough. And therefore, what are the things we're going to employ and pull levers on that are going to mitigate that? Because it just can't all come from clinical services at that level. So again, that's not a list of excuses, but I think we need to get into the finance discussion and say, what are we going to do to mitigate that? Because with the performance improvements we're seeing, the vacancy freezes we've got, we're doing better than ever and still not even nearly closing 40 million at risk. So that's our big issue, isn't it? So I know you know that, Mike, but it's just I can't see how further performance improvement on one site is going to double that recurrent delivery.
Can I come back on that, David? Yeah, I think that's really helpful. But I think if we can continue to have that clarity about this is as far as it can go in delivery terms, therefore these are the more fundamental things that we've got to look at. Because it seems to me the implication of that gets us into some of the less palatable stuff that we've always said, in theory, what would we do if? But if we're saying performance is going as far and as fast as performance reasonably can, and it's delivering both performance results and financial results. I think it's quite a profound conversation in the term, kind of the second half of that question around, so what happens to the rest of it?
That's exactly what we'll touch on later. So we've basically had to focus on closing the 2 stretch targets to identify the total number, which we've just about, as Rob will report, we've just about got to now. So, you know, we close the stretch target for the totality of the number, but of course all of that needs to deliver all year, doesn't it? So then you come back to, right, well, if the Royal are then £1.5 million behind a month or whatever, what are we going to do to close that next? So Rob will indicate sort of how we've closed the totality of the position, non-recurrent actions, but then importantly, this next week, we are literally into which teams are going to be halved in the organisation, which services are going to be stopped, because the residual issue of being behind on any month when you've got 1,180 people to take out just compounds, doesn't it, month by month? So that's where we are, Mike. So the focus for the first couple of months has been get solid plans so we can at least deliver a full CIP, really push the recurrent nature, but we know the mitigations then are going to be the really unpalatable stuff now, because there's not a lot. And I'll when Rob's done his presentation, I'll fill you in on the turnaround directories arrived this morning and what they're going to start to look at in that regard as well.
Thank you. That's really helpful. Thank you.
And Jackie, please.
So mine's not about finance and performance, so I don't know if anybody else has got anything on that. Mine was around the critical care staff.
Sorry, you go. You go.
Okay, lovely, thank you. So it's really to understand the issue about domestic services and those vacant posts, and then the consequences of potentially of those. We've got to find out through the IPC team, but I'm just really concerned that we're stopping recruiting frontline staff. Same in critical care, that then it's having consequences to us. So I suppose it's to understand what we're doing about escalating that outside of the organisation, and also have we got any other emerging risks which may have consequences to our patients? Thanks.
So just for clarity on that, Jackie, they're 2 slightly separate issues. So from a domestic perspective, the issue is that in the rules that have been put in around roles, the ICB class those as non-patient facing, non-clinical roles, so they fall under the vacancy control restrictions. So that is where Rob has been working externally and has escalated that, and we are putting the vacancies out, even though the rules are we shouldn't be putting them out, but we have assessed the risk, and because of the risk to patients and the services, we've put those vacancies out to support the teams. So that's the domestics. So we're in train now to get those in and recruited. The crit care, we're out for all vacancies. We've put no controls over establishment of crit care. The issue there is we've just changed our bank rates of pay, and the staff were unwilling to pick the bank shifts up at that new rate of pay. But just from your perspective, we have daily oversight of that through the divisional nurse and the director of nursing. We monitor the fill rates every day. As I say, this week there are no issues, and going forward they have recommenced picking the bank shifts up. So at the minute there is no concern over that, and there is an escalation protocol that David has circulated. So if there was an area and we were concerned about, there is a clear escalation through to execs now for those areas to be raised.
Yeah, so I'm still at the bit now. It's about external influences that are stopping us doing what we would normally do, aren't they? Whether it's through bank rates or whether it's through stopping vacancies, and how anyone can think that domestic staff are non-clinical facing, I'm not quite getting it. So it's just really the pushback to the ICB about some of this stuff, because this is now what's going to be in the future.
Yeah, John.
Yeah, just on that, Jackie, absolutely agree. We get this stuff every week emailed out to us that says, here's how many adverts you've got out, including clinicians, and we're being challenged on why we're recruiting clinicians. So in all of these circumstances, we're just doing what we need to do, and then it's sort of explaining why we're not complying rather than complying and then having the argument. The issue with the domestics was one where I think there was a bit of confusion because it was sort of an enforced freeze. The bank rate work has been really difficult and contentious across all the trusts, as you probably know. We've had some good assurance through David and the sites of the execs that our move to the midpoint has been very well handled and managed, and everything's being filled that we would expect to be filled. And likewise, I'd seen similar over at Heart and Chest this week. But we shouldn't underestimate the sort of morale impact of it as well, and that discretionary effort that starts to sort of slip a little bit when these things happen. But we've got good assurance on that. So there was a paper yesterday that came to exec, on Tuesday, that analysed the impact since the bank rate introduction, the impact on agency and the impact on HCAs. So again, we'd be happy to circulate that for Ned's view, if that's helpful, just to give you further assurance on that.
Thank you. Tom, next, please.
Thank you, Dave. It's an extremely general comment. I'm very impressed by some of the efficiency savings that have been achieved and the fact that we've de-escalated and closed so many beds. I guess I'd like some reassurance that we're not creating a brittle organisation that has no resilience to withstand external forces like a sudden rise in flu or whatever. That can we re-escalate if we need to?
Yeah, on that, Tom, I mean, one of the good things, there's good things in terms of running a hospital in the way that you'd like to run it, and then there's the financial ask, isn't there? So the good news we should all be very proud of is because our staffing rates are all right up at the very top end of where we would want them to be. That's a financial consequence, but it's a good financial consequence because we've got lots of good substantive staffing. So even in this bed closure situation now, we'll actually have a surplus of nurses that will allow us then to do some other things. So one of the things, for example, that we're discussing at the moment is whether we provide more palliative care because of the absence of the Marie Curie services that are stopping in Liverpool. If we were to do that, that will be a significant contract for us to do. And actually, by the ward closures and the efficiencies that have been made on urgent care, we now have sufficient staff to be able to move into that quickly and respond. So in a way, we're probably less brittle and in fact could re-escalate more quickly than we could have done previously because we've managed that demand down. So we're in a probably better position. The risk, of course, is that we don't want to end up in a position where we've got a surplus of staff on the payroll that aren't doing anything, but we're certainly not there.
Jane, if I can just add to that, the other thing, Tom, for me is one of our biggest problems in last year's winter planning was the Royal, as you know, has no escalation capacity anywhere, and we ran into it with full wards. So if we can de-escalate, it actually gives us flexibility for winter escalation, which we have not had for the previous 2 winters.
Sue, please.
Thank you. Just wanted to pick up on the bank rates, and that's really good to hear, James, that some analysis has been done and on the impact on agency, etc. But I just wondered, have we extrapolated forward into the winter season in terms of the drop in the bank rate and the goodwill in doing those additional shifts at a lower rate? Do you foresee an issue, in the coming months?
Not really, because our staffing rates now are so good that we're well ahead of where we would have been in previous years going into winter, and they're not. The bank rates are still being picked up at the same level now, even in sort of holiday season. So no, don't see anything particularly. But I'll bring David in. He may want to add to that.
Thank you, James, and thank you for the questions, Sue. So just to clarify for colleagues, this is for band 5 and above posts. 2s, 3s and 4 band colleagues aren't impacted on this because there is no midpoint for those roles. And so those areas where we perhaps we are using more bank staff for that enhanced care, especially one-to-ones, we've continued with that as appropriate. We've also seen the ways in which we've done that, reducing those staffing numbers required safely and sensibly. The issue about the longer term issue for qualified staff picking up bank shifts, I think it's a little bit too early for us to be able to understand what that impact has been. For us, we've only been in this situation for a month. We started on the 1st of June, so it's a little. I think it'll be a little bit early for us to have any true projections. However, as James mentioned, our vacancy rate within RNs within the organisation is probably the lowest it has been since the organisation joined itself together in 2019. I presented a staffing paper to execs yesterday that will be presented at board next week that will demonstrate some of that greater I hate to use the word, greater resilience that we now have within our substantive workforce. But it is something that we've got to be mindful about that longer term impact on bank rate, Phil.
Okay, thank you.
Back to Natalie, please.
It was just to say, so in winter, the main issue is usually in the emergency department and the critical care unit where we see the increased pressures. We've got plans at site of where you would redeploy staff to support those. So it's all part of our winter plan, and we have matrons, we have PEFs, etc., who aren't included in the numbers, and we have escalation plans if we needed to support patient care. So we have all of that in hand.
Thank you. It's very good. Excellent. Right, let's move on and talk with Jenny, Liverpool Women's Hospital Management Board, please.
Thank you, Chair. So yes, we had our management board last week, and one of the first things we noted was the announcement of a national investigation into NHS maternity and neonatal services announced by the Health and Social Care Secretary, and that's aimed to drive urgent improvements to care and safety. The Chief Executive of NHS England held a briefing, I think it was last week, which myself and Jim attended, along with the Medical Director of the organisation here, and there's another national briefing taking place in about 2 weeks' time. There are 10 trusts identified in terms of the initial review. We've not been identified to my knowledge, and actually we're putting ourselves into a position where we would like to support the review in terms of some of the improvements that we've made over previous years to support the national review. So I will update on that as we know more. In terms of other areas for escalation, we noted our financial position, reporting a year-to-date deficit of 3.2 million against a deficit plan of 3.2 million. And whilst that was on plan, we noted that there was some non-recurrent delivery within the cost improvement programme. It had reduced in month 2 to 100k delivery versus 300k non-recurrent delivery in month 1. Nevertheless, remains an issue for us. We have a cost improvement programme board that meets weekly here at Liverpool Women's, and that's really pushing forward progress against those schemes. We do have all of the target of 12.7 million identified, but similarly to that, there is some of that that is still rated red, and that's 3.4 million, and we're working through that to move that on in terms of getting that into delivery. Just for context, there's 239 schemes that Liverpool Women's is managing through the SIP programme board, so there's quite a lot in terms of volume to manage. Just picking up on whole time equivalents, you'll recall that Liverpool Women's actually has a plan to increase whole time equivalents, and that's in relation to Birth Rate Plus, the Liverpool Neonatal Partnership, which is funded and commissioned, and some of the safety actions that we're continuing from last year's improvement plan. That said, the cost improvement plan also includes 57 heads out. So we are working on that. We had 16 out by month 2. We have run a mutually agreed redundancy scheme, MARS, within the organisation, and there's 15 identified through that, and then 26 with some individual schemes allocated to them. You'll see in the high risk report, cash remains a concern, and I will pick that up when we go through the high risks. So moving on, there were no new risks identified by the Hospital Management Board. However, we did note that we have got ongoing risks in relation to imaging capacity, which are under review, and also, again, similarly to the other sites, risks in relation to the changes in bank and agency rates, and there's a potential uptake of shifts and fill rates. Our busy season in maternity is September. In terms of our peak, so that's a little bit closer. So we've got a real eye on that in terms of uptake of bank, but you'll know that we're fully established in midwifery at the moment. So we'll keep an eye on the ongoing impact on that. And we also got to the discussion just around that longer term workforce planning and some of those issues where we're seeing nationally and locally difficulties in recruiting and filling posts, and how we're going to get a bit more intelligence into the workforce planning in the longer term. On that basis, we have in the past created roles such as neonatal nurse practitioners and advanced care, just in terms of where we're seeing gaps and getting some training through. So we were having an eye to that in the future. In terms of performance, some of the key areas for us, it's all obviously in the IPR and the report. We noted that the 28-day faster diagnosis standard was just below 75%. Group ops team supporting us with that, reviewing that position with some validation. So we'll test that. We also noted some issues around the DMO1 standard, which is the diagnostics performance, and it is linked intrinsically to the imaging risk in terms of we've had some absence in that team. We are seeing some returners to that, so we will keep that again under review. And you will recall from last month's board the issues around 62-day performance and the action plan that we've now got in place. We went through that at the Hospital Management Board. We also had a system oversight group yesterday where it was referenced in terms of the progress against that, and a Tier 1 cancer meeting the day before. I think it will be helpful in a couple of months' time to bring progress against that back to the board, I think, in terms of where we are up to in the plan that was demonstrated last month against those key actions. And just to note as well, as in terms of elective performance on the whole, similar issues around ongoing delivery in the context of being unable to use waiting list initiatives, looking at the bank rate issues. In previous years, we have insourced to help us with our elective recovery, which we're not able to do this year. So that for us is an emerging risk in terms of our ability to maintain and sustain that. I won't go into too much detail on CNST and the perinatal dashboard because that has got its own agenda item. I think
Jenny, Jenny, sorry to interrupt you. Whether right now or in the thing, I think it's just better for the flow of the meeting if we deal with those two papers as part of your overall update.
Absolutely, no problem at all. In which case, then the final thing to report is that we approved the soft facilities management proposal. So in terms of how that will be delivered in the future, I've not put any detail in the paper as it is commercially sensitive at the moment, but our head of estates and facilities will bring that to the private section of the board next month. But we did approve that proposal in our meeting. So fundamentally, I think the three themes coming from Liverpool Women's around our concerns around achievement of the cancer standards and how we come out of Tier 1, and indeed the potential emerging risk to elective recovery in the context of the financial issues that we're facing, and then linked to that the financial position itself, which is unsustainable, and the access to cash, which just reminded me of not taking you through the high risks. I'll do that shortly, and then our isolated site position, which in the context of moving forward, and as we've got the board assurance framework at a group level now, which is further on the agenda, how we ensure that through the Hospital Management Board and through this committee that we've got really good sight on those isolated site risks and the work that's being performed through the Women's Services Committee. If you don't mind, Chair, I'll just jump back to the risk register.
Yeah, sure.
If that's okay. Apologies for skipping over that accidentally. So as I say, there are no new risks. We have 4 risks, which are 12 and above. First one in relation to meds management, which is scored at 13. We had some conversations through the Hospital Management Board and with the Deputy Chief Pharmacist in terms of the approval of the business case and the actions that have taken place since then. That has led to an indication that score will decrease as a result of an increased score in the controls that are in place and are being put in place in that area. We think that will remain a 12, however, and still be escalated, but it is moving down as a result of the actions that have been put in place. In terms of the financial risk, I won't go into that because I'm sure we'll pick that up through the financial agenda item. I think just to note the cash risk is getting more and more imminent for Liverpool Women's in terms of the requirement in Q2, and at the moment we have not been confirmed that we will receive that cash. We were fortunate in that the maternity incentive scheme paid the achievement of year 6 this month, so that's helped our cash balance, but I'm sure Rob will pick all of this up when he goes through his report. So I will pause there for questions. Thank you.
Questions, please. Yes, James.
Jenny, just on the registered nurse and non-registered nurse staffing, if you look at it, midwifery looks okay, but on nursing, the night on both looks like it's deteriorating, and there's a statistical deterioration, particularly on the non-registered. What assurance can you give us around that? Because I know we've spoken before about the ability to use bank, etc., but the fill rates don't look great on nights.
Yeah, so we've had this discussion with the director of nursing in terms of, and you're right, the evidence behind it. Some of that depends on the acuity, particularly in neonates, and the spread across the cots and what is required on the night. There's been no reports of any issues, no reports of any incidents in relation to this, but I can bring some more detail back if that's helpful.
I think it'd just be useful, a bit like the conversation we had before about that.
Yeah.
We sort of take it on good faith that if there's a problem, we know about it, but
yeah,
it's quite concerning to see the numbers statistically deteriorating with no assurance around, well, what is that because there were a lot fewer neonates in the month and therefore we didn't need to staff it. But it would just be useful to have a bit more evidence of that, I think.
Do that. Yeah.
Mike, please.
Thank you. Thanks, Jenny. The perinatal sickness absence, midwifery sickness absence, which has been read for best part of a year now, I think. 58% is weighted towards long-term absence. So just a question around assurance that we are actively managing long-term sickness absence, please. Thank you.
Yes, absolutely, and yeah, the team are really cited on it. Our director of people is working with the maternity leadership in terms of being supportive for those long-term absences. Some of them are severe long-term absences, which are legitimate, and we are supporting through that. I think for us, in some ways, it's the short-term absences which are the most difficult in terms of being agile with, because we don't plan for those in the same way as we do the long-term absence. We've got some return dates for those others. We've got fixed term covering some of those longer-term absences. So yes, they're being managed within the policy.
Tim.
Thanks, Chair. Hi, Jenny. It was just a question on the sort of inbound national review of maternity and what, if anything, we know about it, because I just sort of wrote down the Saving Babies' Lives agenda, the Ockenden review, the Kirkut review that came out of East Kent, the maternity incentives and the long-term plan, the maternity incentive scheme, the maternity transformation plan from NHSE previously, the CNST agenda. It's a really crowded pitch, isn't it, with all these sort of national interventions? So do you think we may be hopeful of a clearing of that, or is it we need to wait and see what's likely to transpire?
Yeah, we need to wait and see. There were a lot of the questions that were coming up in the initial briefing, Tim, around what's the terms of reference for the investigation, how does that fit in with all of the things and all of the reporting that we already do through those various routes. I think it is recognised that it is crowded, and there needs to be a better way, a more effective way to manage going forward. And within those discussions as well, Tim, came the conversation around tariff and how, you know, with the additional asks and requirements, how we fund those, and particularly in the current context as well. So I think we will know more in 2 weeks' time when the meeting is held in terms of the terms of reference and more detail around the announcement.
Helpful, thanks, Jim.
A matter of detail from the IPR, if I may. It's the A&E treatment within 60 minutes. This doesn't look terribly clinically significant because it's not going anywhere for a long time and people seem relaxed about it. So I just wonder if you can reassure us on that.
Yes, so that's the gynae ED, the gynae emergency department stats. We are overwhelmed a lot of the time in terms of footfall coming in. So it's not where we want it to be necessarily, and we see some of that through the friends and family feedback. So the gynae ED is under review in terms of effectiveness and efficiency and how we deliver those services. I think once we've got the door open, people tend to come in, given the long waiting lists as well. So we are managing it, we're on top of it, but we need to do something a bit differently.
And Jackie?
Thank you. Jen, it's just around the governance around the medicines management, and we've known for many years that through CQC inspections we have some issues around that, and they don't seem to be moving in a way that we would perhaps want them to. So I'm just wondering, with the work that is being done now, is this going to be addressing the governance issues, or is it about appropriate service levels?
Yeah, so it's a bit of everything, Jackie, in terms of the site. Well, so just give you a bit of context, there is a group transformation plan around medicines and pharmacy, of which we are a pillar. The business case to address the issues around governance were multifaceted in terms of education, in terms of site sort of presence, in terms of roles on the site. So we're working as part of the group and the other sites in totality with those issues specific to Liverpool Women's as well. The business case was robust and took each of the risks as articulated, and there were a lot. The one that you're seeing at 13 is the overarching one. There are a lot of individual sub-risks being addressed, and we wanted the business case to map to each of those risks and each of those issues as we know them, to address it with the additional investment required to address those and turn that dial. So the action plan is in place, Jackie, and as part of the group.
I suppose I'm just thinking, as part of the group now, you know, we don't want to see some disparities between services. So it's just about, is anything extra that as the group board we should be looking to support Liverpool Women's with?
Yeah, thank you, Jackie, because we had that. Obviously, Pip, our chief pharmacist, is across all of the sites and indeed some others, and we've had those conversations about what at last, if we look at all those organisations and we've got disparity in resource, can we level more fairly across all University Hospital Liverpool group and LASP, and Pip is very conscious of that ask around how we don't have the same level of disparity potentially between individual organisations.
Matt?
Thanks, Jenny. Good to see continued improvements on e-news compliance. Just really around your confidence in sustaining that.
Yeah, no, absolutely, Matt. There's been loads of work in that space and in e-news as well, which should be in the IPR, so the maternity early warning scores as well. That's been a piece of work through the transformation plan last year, the improvement plan last year, and absolutely there's no reason to believe it wouldn't be sustained given the level of education and process that's gone into that.
And Jeffrey?
Thanks, thanks, good report. Back to the staff absence. I think I mentioned the last board, could we have a breakdown between long-term and the short-term absence in the IPR? Because obviously you raised the issue, that's the challenge. Is more less long-term, more short-term.
Yeah, we can provide the breakdown. I guess it's would you want that for all organisations or just Liverpool Women's, or is that just something that would be a helpful?
I think for all actually, it would be helpful to know, because it's always useful to know between the breakdown between those who are short-term repetitive and those who are long-term.
Okay, thank you. Jenny, is there anything now in items 10 and 11? You've made reference to the incentive scheme and the perinatal dashboard. I'd like us to receive those now at this part of the agenda. So is there anything else you wish, the good reports, anything else you wish to highlight out of them before I?
So just very briefly then, as I say, we've been through these in significant detail at the Hospital Management Board with the Director of Midwifery and the Head of Midwifery and the wider Family Health team. We are into year 7 of the maternity incentive scheme, which I reported to the board last month, is very similar in terms of what we need to achieve with some slight amends. There are no areas of concern against safety actions. I think just 2 updates really. On safety action 7, in the paper we talk about awaiting funding notification in terms of the MVP, the Maternity and Neonatal Voices Partnership. We have had confirmation yesterday that we will be receiving, I think it was 11k funding on that, so that can continue. And it's not raised as a formal risk yet, but we did note that the level of compliance and the prompt training, particularly through our resident anaesthetists in training, is a concern just in terms of where it's at and its percentage. And we know that that's one area that towards the end of the compliance cycle, we tend to have to put a bit of focus on. So that was just a little bit of an early warning, but nothing to particularly be concerned with for now.
Thank you. Are we content to receive those papers, please? Just don't let me choke off any questions or concerns anyone wishes to raise. We content to receive them. Thank you. Well done, Jenny. Let's move on. DTC board, Beth, please.
Thank you, Chair. So I will just focus on the risks because that covers the main issues that we discussed in the meeting. So we have 6 12+ risks across the DTC. 2 remain the same level, 2 are new, and 2 have increased. So the 2 risks that have remained the same include CIP for pharmacy and the challenges in delivering that. The mitigating actions there are a focus on the provider-to-provider contracts for aseptics and radiopharmacy. We are working through the detail of that with the service managers, and we're looking at the costing model. So that is one of our main challenges against that risk. The second is 12, that has remained the same, is to do with the strike action in LCL. And following discussion and following the step down of the more recent strike, we are looking to downgrade that risk from a 12. The 2 new risks, 12+, include the CIP for imaging and the challenges in delivering that CIP. The mitigating action that we're focusing on is around the premium pay control and the alternatives that we have in delivering the service across the sites and the impact that could have in changing those rates. And the other new risk is around the administrative support to the 13 senior leaders across pharmacy. This will be downgraded, as we talked about that in the vacancy panel yesterday, but at the moment we don't have any support for those people, but that will be reviewed and downgraded. And the 2 increased risks include the pay inequalities in LCL. That is around some, well, we're the only one really that don't pay an RRP in blood sciences, and it is something that is a bone of contention that keeps being raised. The mitigating action there is that we are going to work with the network and also with the ICB in terms of trying to get equality across the system. And the other risk that has been increased is around pharmacy and the lack or insufficient support for pharmacy in the Aintree ED. The mitigating action there is that Aintree have supported a business case for a fixed term to increase the pharmacy support in ED. So they're the only things that I'm going to pull out of the report, but I'm happy to take any questions. Thank you, Chair.
Thank you. Which questions did James?
Yeah, just on the what I like about the LCL report, it's a bit easier perhaps to look at sort of capacity demand. So the histopathology cases received versus histopathology, the same cases reported. There's clearly a discrepancy, and we're reporting less than we're receiving. So you can sort of see an endpoint coming here where there's going to be a big problem. Don't need to answer the detail of that now, but it was more about the given we can see that sort of emerging. Is capacity demand quite well understood within that board meeting, Beth? Are they looking at that discrepancy and what they might do around it?
Yes, so we have talked about that. We're on our second meeting, but we have got into that already. There is an improvement programme around demand management, James. So there is a gap in some of our services, and you've picked out one of them, but some of this is around the management of the demand that we receive and the alternatives and options that we have available to us.
Yeah, I mean, the good thing is it looks like the cancer ones received and reported are pretty even. It just looks like we'd be starting to build a backlog in histopathology more generally. So
yes.
It's good that they're onto that. Thank you.
Good, thank you. Jeffrey, please.
Thank you. Really, congratulations, Beth, on the solving the industrial relations problem. I was doing an engagement visit last week, and you could feel the tension. So just to say, well done. I don't know what you did, but clearly it worked.
Don't tell them what you did, Beth.
I think just in response, I think in response to that, Jeffrey, we do have issues in LCL, and I think what's been well received is actually listening and then responding, and we have got a number of actions that we have committed to, and I don't think they're unreasonable. I think that there are legitimate concerns that people have raised, and that's what we are attempting to address. It still remains an active kind of ballot, and so we have to deliver against the commitments that we've made, but we're making sure that we are routinely and rigorously monitoring the progress against the commitments we've made. So that's important.
Well done.
Thank you. We like routine rigour. Sue, please.
Just a question around SIP. As with all the other presentations, there are challenges there. Could you just put a bit more flesh on the bones in terms of values, what's been achieved and how much is in the red category?
Okay, thank you. So our target is 9.2 million across DTC. Against month 2, we have a £230,000 variance against plan. As I've said, there are varying challenges across the 3 areas. LCL are delivering against their financial plan. Our challenges remain in imaging and in pharmacy. So I don't know whether you need any more detail there, Sue, but it's 230,000 variance against plan for month 2.
So in terms of the 12-month period, how much of that is still unidentified?
Unidentified, there's around £1 million unidentified across the 3 areas.
Okay.
And what we're trying to work through is the recurrent versus non-recurrent.
Okay. Yeah. And plans are in place in terms of identifying that additional million and progressing that, I assume.
Yes, we do. We have schemes across all the 3 areas.
Okay, thank you.
Jeffrey, please.
Sorry, it's a legacy hand, Chair. Sorry.
No problem. David, please.
Thank you. A good report, Beth, and share Jeffrey's praise on sorting out the industrial relation, or starting to resolve the industrial relations issue. One of the things you mentioned that I understood was behind it was this recruitment and retention premium. And it's been mentioned for some time now that other labs in the region have agreed not to pay it, but they continue to do so. And we're the only ones that don't pay it, as I understand it. How do we resolve that? You've escalated it, I believe, to the ICB. It seems how can you do business with people when they don't do what they say they're going to do? It seems very strange to me.
Thank you, David. So it's not been escalated to the ICB. That's an opportunity to escalate to the ICB as part of the cost saving schemes. Did I go off then? I'm sorry, but my computer went. Okay. Okay, thanks. So we are going to take the opportunity to, because I think that is something they do need to drive, is that equality. Where we have raised it is with the network, the pathology network, and it is something, that's why I'm saying the opportunity now is to take that to the ICB to see if they can carry some weight. There are real problems in staffing, particularly in blood sciences. And so I understand the reasons why people have done that, because it's an area of which there's a national shortage of staffing in that area. But it's just not helpful that we are, as I say, the only one that is not paying the RRP. So rather than us pay the RRP, it's what we do as a system to bring that equality.
Yes, thank you.
And Jim?
Thanks, Chair. I just want to say from a kind of if you like, a clinical user perspective, seeing a lot more detail about performance in DTC is really helpful. Let's say the histopathology, the pathology turnaround, which we've not really seen before. And there are lots of customers of DTC. The 2 ED departments would be a good example. So Beth, thank you first of all for getting a lot more detail, but there's quite a lot more to go at here, isn't there? Particularly, let's say, around diagnostic radiology performance. So would you just say a little bit about maybe plans afoot to bring some more performance data, let's say, around radiology into your IPR?
Okay, thank you. So at the very first meeting, I asked for an IPR for pharmacy and for imaging, and Matt's team have worked really well, and they have produced one, but the data sources are fairly unreliable, hence the reason why they're not included. We have seen it. We looked at it at the HMB, but we just need to make sure and be confident in the data sources and the data being made available. So that's the reason why it's not included in the pack at this moment, but it's coming.
Thank you, Beth. I think that would be a really positive development.
Yeah, great. Thank you. Excellent. Well done, Beth. Our final site report, Aintree Management Board, and Shahida's here for Peter.
Thank you. Thanks, Chair. So the paper is in the pack. I'll draw out the salient points, but just the first, just to make the board aware, during our meeting last week, we were notified that we got the formal results of the CQC inspection of the medicine division in March. So the rating was good, which is a real positive movement and an improvement from the requires improvement that we were scored at previously. Just moving into the items for escalation, the 4-hour performance within ED. I know Nat has covered most of that off, but also to highlight the site is part of Handover 45 with working with NWAS to look at pathways, which the national scheme commences from August. So the site is well on with that. The other one I wanted to just draw out was time to triage and time to treatment. Within the IPR, that performance is strong, and one of the risks in the pack rated at 12 at the moment, 8247 will reduce to 11 following that strong performance. Moving on to elective performance point of view, delivery of 65 weeks was raised last month, particularly within ENT. The site has set improvement trajectories. The position at the end of May that's included in the IPR is 581 patients. The forecast for June, just being validated, is 250, and the plan is to move to 0 in July. It's an improving position. However, the expectation is, as we've said, is to move to 0 by the end of July. Quite a bit of work has been done in that space. We have a recovery plan that's in place. Additional capacity has been sourced. We've got support from the corporate operations team in terms of validation. We're also working with Cheshire and Mersey, ICB, with a system-wide referral management for ENT, including centralised patient tracking list, and a paper's been finalised by the division that will come to the HLT in the initial in the next week or so, which will then go to the execs, detailing demand and capacity for head and neck, and also consolidating the 65 and 52 weeks during 25-26, and also having a sustainable model going forward. Moving on to the delivery of the diagnostic target in the IPR, that is we're not delivering that, particularly in echocardiography that James highlighted in his report. It's on the risk register as 8645. We have recruited staff into that post. They commence in July, so we should see that risk go down, which will address the demand going forward. However, we have got an issue with backlog. The division are exploring the CDC to help with that. We also discussed on Tuesday possibly asking the commissioners for help in that space as well, to help us get back to a better position. And lastly, just for highlighting The appraisal window is changing from a trust perspective from 15 weeks to 12 weeks. At the moment, the appraisal compliance for Aintree is within target. We're just short of the 80%. However, moving to the 12-month window will result in that performance dipping to 66%. So we will be putting a risk on the register. However, the control we've put in place to mitigate some of this is weekly assurance reports, including staff list trajectories requested by division. We'll be reviewing those on a weekly basis to performance manage how we go forward on that and deliver the target. Moving on to the finances. Overall, the financial position at the end of May for the site was a contribution of 14.9 million against a plan of 15.6. So we were 700k over a variance of 700k. The position reflects a combination of drivers within the position, including the site revaluation benefit that all sites were received that. We've got escalation capacity still included in April and May position, and I'll talk about what we've done to mitigate that. The underlying position, I'd say, would be more like a variance of 1.4 million. In relation to contracted income, or the variable element of it, the trustees report is delivering a position that's in line with plan. So, and we were slightly ahead of plan of 400k. The main area for concern for Aintree is the cost around pay spend. Main drivers are sickness, the escalation, premium pay, and costs of supporting patients with additional one-to-one care due to mental health needs of the patient. We have had particular demand over April and May where we had certain patients requiring 4-to-1 care, which impacts on the fill rates. As you'll see overnight, our healthcare assistant fill rates are at 117%. In relation to non-pay, we are broadly in line with plan. We've got some overspends on consumables within theatres, and there is an action plan to mitigate that. In terms of actions we're doing to manage the financial position, we closed, as Nat said, we closed at the end of May, we closed 50 beds, releasing 83 whole-time equivalents. They were unfunded. At the end of June, so the end of last week, we closed a further 42 beds, releasing 72 whole-time equivalents, and also we were using the discharge areas to bed patients. So in total, we've closed in the region of 100 beds at the end of last week. So that will materially impact the run rate position, certainly at least 500,000. Also, the bank rate reductions that we've just discussed, that will also positively impact the position for Aintree site. Moving on to CIP, cumulatively, we delivered 6.8 million against a target of 5.4. So we are 1.2 million ahead. Full year effect of our, recurrent effect is 13 million. In terms of green schemes that I would forecast will deliver for the year, it is a further 3 million, so we should get to at least 60 million at this stage. However, the plans are progressing well. We have had one-off benefits in the position. Excluding that, we would have an under recovery of in the region of about 1 million on CIP. In terms of the target, we've got, our target is 35.5 million. We have identified all of that. We've got 2 million that's in red and 13 million that's in amber. That, for me, that element is the risk element for the site at the moment. We have got transformation plans, and I know the touch time was referenced before. Orthopedics is one of our schemes for transformation, and theatre productivity, touch time, etc., is included within that. I'll summarise it in a couple of minutes, just in terms of the further work that we're doing on whole-time equivalents. There is a plan to close one of our corridors at the end of July, which will release 30 whole-time equivalents, and also a further ward in line with the non-criteria to reside work. That's planned for the end of August, which will release a further 2 million if we achieve that. So there are significant plans in place to manage capacity going forward. In terms of whole-time equivalent reductions, we did reduce 118 whole-time equivalents from the budget for the first 2 months, mainly in relation to A&C vacancies that we retracted from the budget. We have got a quarterly plan as to how we're going to deliver the Aintree share of the overall trust ask of 1,200 whole-time equivalents for quarter 1 through to quarter 4. In terms of significant risks, we've got 13 risks that are scoring above 12. One is scoring at 13, which is in relation to ED and discharge, which Nat has covered as part of the urgent care update. We had two risks that were escalated. They relate in relation to vacancy controls within outpatients for admin and clerical staff, impacting slot utilisation and also booking. We have appointed some vacancies, and once staff commence, that should mitigate some of the risk. And we have asked our people and OD group to look at providing oversight, triangulation and management of that risk. We had 3 new risks, 2 relate to finance, which is CIP and expenditure, which I've just discussed, and 1 related to prescribing and admin errors in ED, which Beth has referenced there, and that is supported. There's a longer term solution being developed in terms of how we can mitigate that in conjunction with the pharmacy team. There's 7 risks that remain at 12. They are in the pack. I wasn't going to talk in detail on those, but happy to take any questions. And just to summarise the position, then I'd say UEC is a risk for Aintree. The work is ongoing that Nat has just referenced before. RTT, we've got a plan in place and to deliver that for at least till the end of July, and then a plan to do the rest of the year. Finance, CIP and expenditure is a risk. The run rate has remained stable, and with the actions that I discussed, that will reduce the run rate going forward. And CIP, as we said, there is a plan to deliver. There is confidence, at least around 20 million of that we think we've got in blue and green at the moment. Happy to take any questions.
Thanks, Sheila. It's a very positive report on progress that's being made. You should come to these meetings more often. It's excellent, thank you. Any points, questions for Shahida? To start with Sue and then David, please.
Yes, thank you, Shahida. I just wanted to seek some clarification really around the closure of the beds, which sounds great, 100 bed closures, and the reduction in the whole time equivalents. When those beds are closed, the impact on the staff numbers, is that sort of immediate? I mean, how does that actually work? Is it sort of bank staff stepping down, agency staff? How are we eliminating those the staff numbers when we close those beds?
Yeah, and I needed to reference that, so you've reminded me. So staff that are, where we've closed the wards and staff are then redeployed into vacancies elsewhere. Where we've used bank and agency, that's easier to manage. However, we have got sufficient vacancies where we are able to redeploy staff into those areas. I had a conversation with our nurse director previously, and what she said was we have enough turnover that we can manage within that. As we close more wards, I think the ward that we're planning to close in August, I think we'll need to think about how we manage that and how we redeploy staff, because obviously redeploying at least 155 with the staff, the areas that we've closed so far will take us, will be managed. That should be okay within our current resources.
Okay, so we're sort of redeploying staff rather than sort of eliminating those positions completely, if you may. Right, okay. And in terms of run rates, if I can just follow up on that, you reference the run rates sort of obviously reducing with the reduction in bed numbers. So is there a net positive impact on finances as a result of that? Or do we lose income because we've got fewer beds in action?
It's a net positive impact on the run rate.
Okay, thank you.
David, please.
Yeah, thank you, and thank you, Shahid. It's great to hear the progress that's being made. And just one really detailed question, please. Could you explain to me on the staffing reports? It talks about non-registered night staff being staffed up to 117% of the target establishment, and that doesn't feel like we're trying to cut costs there. It feels like there's an opportunity there that we could reduce costs further. Is that my misreading the data, or is there some flexibility there to take out costs?
David, you come on this, please.
Thank you very much, David. David, you'll recall that last year we were looking at fill rates on nights of 125, 130%. And so what we've been able to do is we're safely reducing that as part of the work around enhanced observations of care. And we know that there are some areas within our organisation where we have patients who require, excuse me, more than an additional member of staff, sometimes 2, 3, and even 4 members of staff. And I think that what we've seen, that there's been episodes on the Aintree site as well as the Royal where that's been the case. With a safe staffing paper that will come to board next week, we'll be able to demonstrate how we're now in a better position to be able to identify a capacity within the establishments to provide, I guess, routine enhanced care, and anything above that will require us to have a bank. Overall, our bank use has reduced on both sites, but absolutely 117% on nights for healthcare assistants. I think it really just demonstrates some of that additional support that those patients have required, but it has reduced.
Right. Thank you, David. Look forward to seeing that paper, and thank you, Shahida, for that great report. Thank you.
Excellent. Thank you very much. Daniel, we got the paper on the BAF, please, and the proposals for this year.
Yeah, just very quickly, we're presented this came out of the board workshop that undertaken in May. These are proposals. We will be having further discussions at next week's Board of Directors. We are just placing it on the agenda today. If any board members wishes to make any comments in advance of next week's board meeting, if they could submit those through to myself and the corporate governance team. If there are any specific areas missing, that would be great. We feel that we've captured the essence of the discussion. At next week's board meeting, executive directors will be providing an initial commentary on the risks set out in the paper, together with views on their assessment of the initial scores, so that we can have further discussions at the board. But that's all I was going to say today, Chair.
Thank you. Everyone content? Yeah, thank you very much. Okay. Last substantive item for us is the 2 finance papers, the month 2 update, and then the financial plan, performance against plan. Rob, in the risk reports, we've had some trailers and teasers for all of this. Can you bring it all together for us now, please?
I can attempt to, Chair, thank you. I do have a presentation that tries to synthesize where we're at overall. David, if you don't mind me using that. Yeah. Okay, so first slide, just next slide, please, Holly. Just to note that I think we have got to recognise that there's been really good progress made up to month 2 in many areas, not least audit completed, unqualified opinions, both organisations, no weaknesses or recommendations noted at all for governance in both organisations from external auditors, some good assurance. Internal audit opinion received, substantial assurance, again on both organisations. So I think that does give us some assurance. CIP is identified, I'll come back to this at Luft, and on track. in both organisations. So again, in fact, we're ahead of the curve. I'll point it out. Variable spend has reduced year on year for the same period of time. We did put in some interventions mid-year last year, so we would anticipate that, but it's worth noting, for example, at Luft, 10% bank reduction year on year, 31% agency year on year, which is good, although not the whole story, as I'll point out. Bed closures you've heard described, and small efforts, Ward 25, Ward 17, Surge 1 and 2 now, the Aintree ED corridor reducing, and more to come. So we are making headway there, as you've heard. Budget WTE reductions are happening, so there's 161 net reduction, but again, I'll highlight on that in a second. Non-pay is on track, including the site revaluation. There is a one-off benefit, but nevertheless, it remains on track. Difficult decisions are being made in both organisations, including bank rate reductions, releasing annual leave accrual, increasing retail prices, and looking at car park charging as well, and overviewing all our SLAs. So they're ongoing on a monthly basis, and decisions being taken. And the corporate services reconfiguration has commenced, bringing the services together, and we anticipate that will give us some benefits. The contract also for both organisations has been agreed with the commissioners, which again, for this time in the year, is the first time I've been here when we've been in that position. So that's good efforts in both cases. That's the Luft slide. There's an exact same slide for Liverpool Women's, and it's virtually the same positive story across the board in all of those areas. So I won't call it out individually, but it's the same overall picture. So good progress at month 2. Next slide, please, Holly. So our overall position, as we can see from the paper, is that we're on track at month 2. We've hit plan, 100,000 ahead at Luft. It does mask the fact a little bit that at Luft we've accelerated CIP, incorporating the site revaluation of 2.8 million, the annual leave accrual release of 3.9 million, and that's put us ahead of the game for CIP. You can see there 18.9 million versus plan of 13.6, but it offsets the operational pressures of the first 2 months where we've had escalated wards, as we've talked about. Liverpool Women's, again, as you've heard, we're on plan, but there has had to be a little bit of balance sheet availability used to reach it. The cash position, which again I'll come on to as a further risk, is noted. So we have, at the end of month 2, we had 30 million for Luft, which is 8 days operating cash, and Liverpool Women's 5.3 million, which is 11 days. That risk has increased, and I'll just point that out as we go through. Next one, please, Holly. So I've just pulled out a slide for headcount, because as we can see certainly in the Luft position, the key driver and the key deficit against plan remains our position on pay. We're just under £4 million off as at month 2. So I just wanted to explain this, because in the paper we include more details now, which hopefully is helpful, but just to explain where we are and why we are where we are. The pay related budget plan was £70 million, and that had 2 elements: a reduction of 1,200 heads, 1,183 heads, an average of £49,000, and bank, which gave us 58 million, and bank and agency savings of 12 million. At month 2, we have So starting from our opening budget, that 1183 reduction would take us to a requirement of around 14,428 heads to meet our plan. Now at month 2, as you'll see, we are paying less people than budget, so at 15,162, but that is a shortfall against the 1,200 required by 700 whole-time equivalents. If you value that up at the average 49,000, it equates to 36 million equivalent, or 3 million a month, and that's driving the overspend. The other point is bank and agency, because whilst I've called out the fact that year on year we have seen a reduction, because the budget was set when we'd already seen some of those improvements, the target for the year is for bank around 4 million a month and agency 500,000. As at month 2, in spite of the good work and the reducing trend, we've been over by around about £1 million a month, 800,000 in bank and 200,000 in agency. Those two contributing factors equate to 4 million effectively a month. We are off from where we plan to be in pay. The reason it's not 8 million off at the end of month 2 is because of the release of the annual leave accrual that brings us back down to that overall variance. So I just wanted to explain that for Luff, because I think it's key to some of the risks and the actions that we're putting forward and we've taken moving forward. Can I go to the next slide, please? So looking at risks overall, and we've looked at three elements of risk. For CIP, we now have to produce a CIP tracker weekly that goes into the ICB. It has a standard algorithm that assesses blues at 100%, greens at 75%, ambers at 50%, and reds at 25%. If you look at that on the position as at the 26th of June, which was the previous submission, we had a risk in Luft of around about £46 million on delivery, and a risk in Liverpool Women's of 4 million. Obviously, as we move through taking things from red to amber to green, that improves on a weekly basis, we hope. So that's 46 million. If we take a run rate extrapolation, again, just taking our position at month 2, extrapolating it up for crudely for the full year, that gives us a risk in Luft of around, if we stayed where we were and delivered what we'd done, of around about £36 million, and in Liverpool Women's of around about 3.5. And then we've just looked, we will do bottom-up forecast starting month 3, but there are specific items that we just need to call out. The item that has been alluded to is the deficit support funding has been recommended following review of the system risks. The regional team, the Northwest team, has recommended to the national team that deficit support funding is withheld from Cheshire and Merseyside as a whole in Q2 until we give further evidence of surety on the plan. Now, as of yesterday, that's with the national team, so that's not been confirmed yet, but we anticipate that they will accept that recommendation. What that means is that for Q2 alone, Luft will have a cash shortfall of £11.1 million, and Liverpool Women's will have £3.8 million withheld. It can be earned back in Q3, but that will be the impact, which further exacerbates the cash risk. Just a couple of other key items within our plan for Luft is the HMRC claim. It's in at 50% of the claim we've made. The Alternative dispute resolution meeting is set now with HMRC for the 23rd of September. We'll find out there. They are are open to a discussion on that resolution, but it remains a risk. There's also obviously a potential upside as well. The upshot of all of that is that in Luft, the overall financial risk at this point in time we assess as between 36 and 46 million pounds, plus a risk on withholding the deficit support funding, and for Liverpool Women's it's between 3 and 4 million pounds plus the remaining deficit support funding. Both organisations will have cash requirements in Q2 or Q3. Just go to the next slide, please. This is just to note underlying deficit, even if once we deliver our plan, and we had the long discussions with NHSE, who recognise that we have improved over the last years and will continue to improve if we deliver our plan. If we deliver our plans in full, that will leave us at around about a 94 million underlying deficit at the end of the year for Luft and 33 million for Liverpool Women's. Obviously, if we shortfall at all or in our delivery or with our recurrent CIP, that will worsen. So it's just worth noting that. Also worth noting, in line with some of the work we've been doing with them, they're now incorporating that in the monthly returns from Q3 for every organisation across the Northwest. So that's an interesting outcome of that work. Next point, next slide, please, Holly. So what are we doing about it, and what are our actions? We had a number of actions to do. Firstly, we had to close the CIP gap. In the slide I just put up and in the pack, you'll see it was a position at the 26th of June. We at that point had a gap of 6.25 million unidentified across Luft. I'm pleased to say that with the work we've done over the past couple of weeks in execs, and we've now closed, fully identified that CIP. So we've at least got we've got no unidentified value. That does involve, as James has mentioned, looking at all our vacancies, going back and aggressively releasing those, which explains some of that difference between budget and paid WTEs. Also includes repatriation schemes that we've had agreed with the ICB, and additional discretionary spend, waste reduction, devolved savings initiatives. As James has mentioned, we have ICB support who started with us today, 3 days a week, to help drive that initiative. So good news, full CIP now identified. Second item is continuing to de-risk plans, and as you've heard, site governance is fully established for continuous review of CIP plans. We look to accelerate schemes where possible, obviously linked to doing that safely and with those drivers of no criteria to reside, etc. In the corporate areas, we look to fully transact all the CIP by month 4. If at all possible. We're about 73% at the moment, and any we're looking to any recurrent with our principle being recurrent unless clearly one-off items. We're still looking at new schemes to fill the hopper because we recognise there will be slippage, and obviously James is with us now. Commercial. Full review of commercial opportunities. I know private patients is the first area to look at, so we need to see if we can go further on that. We've talked about the benefits from the Broad Green and Heart and Chest site and coming together, and we need to assess that, and David's talked about a safer staffing review, and there'll be some potential financial benefits there as well. So we continue during June to de-risk plans. The third item, though, is the reduction in the pay run rate. And so, as we've seen, we're paying below budget as it is. We've closed the gap, but with this 730 shortfall from where we thought where we need to be, there is further work to go. We've heard that there will be benefits from shutty wards and other actions. But what James has initiated is a review of established services and teams to see have we got duplication we can eliminate, and are there actions proactively we need to take to right size our resources to get back within that pay envelope. The fourth item, just to note, is cash management. There, as we talked about, we will run out of cash in August, Liverpool Women's, September for Luft. What we are putting forward is an interLASP approach. That includes advance payments, deferring debtors, capital prioritisation plan, and ultimately a PDC transfer. It's important the ICB have put forward and are developing an MOU for cash management. What we're trying to do is contain our cash within the Liverpool system and between the LASP organisations. So that work is ongoing and at quite an advanced stage. So they're the priority risks we've identified, the actions we've taken. Just a final note to say, we had the Simon Worthington review come back. He identified that there was risk in everybody's CIP plans from his review at month 1 across Cheshire and Merseyside. Luft were noted as amber, Liverpool Women's were noted as amber, as were Liverpool Heart and Chest, as were Clatterbridge. Walton Centre was red on that metric. The PwC system report is due to diagnostic assessment is due to report back to CEOs and CFOs tomorrow. So we'll understand what that says. The anticipation is that PwC will in some way be involved in supporting getting the system back on track. That's where I was going to leave it. Happy to take any questions, Chair.
Thank you. Clear, very clear presentation. Good structure, helps us think through the issues, but some very challenging numbers and issues raised in there. Thoughts, points, questions, please. We've got Sue to start, then David.
Yes, thank you, Rob. Just had a question around cash. There's a cash management plan in place with LASP. We've got the significant challenge taking place in August in terms of cash. With the actions we're taking with LASP, will that eliminate the risk in August, or do you think that will still be there? And if it will still be there, what is the plan?
So the backstop plan is to apply for distressed funding. We've been doing that, done that during last year, and we will do that again. So that's an arduous process. So we will apply to NHS England. They are now. Last year they started saying no one can have any money at all. They've kind of loosened on that a bit, but we still have to go through a process. So we'll do that. Our work we're doing across the 5 of us should at the very least push that back a little bit. We've just concluding there are things like we're already getting advance payments from organisations for charges for the in-year. We're exploring whether we can invoice in advance for say 2 years ahead, and that can help move cash around. We have to just be careful for the giving organisation to make sure they can demonstrate value for money. So we're just doing that cautiously. The financial controllers are working really hard on this. I'm hoping that in the next week we'll have a real proposal to take to organisations. Okay, so hopefully she'll push it back a bit, Sue, but it's not going to eliminate it, particularly on Liverpool Women's fully for the year.
James on this.
Yeah, could just come in on the cash point. Rob, am I right in thinking that there's now a national move to free ICBs to effectively move cash within ICB systems? And within that, given most of the cash is in Liverpool, might we expect that, you know, we've got a plan to move cash within LASP, but actually some of that will leave the sort of LASP environment potentially to support other organisations in Cheshire and Wirral and so on?
Yeah. There's this MOU that ICB are developing is there was always the opportunity to do it. No one really did it. What you have to do is give up. An organisation needs to give up PDC, give it back to the system, and the system can then determine where it goes. What we're trying to say is, if we can do that within LASP, that would be better, obviously, for us, because we don't want, you know, frankly, we're system players, but we've got enough issues in Liverpool to utilise that cash. So yes, that's the route, James. Basically, paying back PDC and redistributing that. There are other cash management items, such as paying contracts at the start of the month or delaying paying them, that they're also exploring.
Thank you.
David, please.
Yeah, thank you, Chair, and thanks, Rob. Very clear presentation. I'm sorry if it was there and I missed it. I couldn't see any references there to funding for the new Royal Hospital. Is that something that's dead in the water now? I mean, it was accepted previously as being a valid case. You didn't mention it.
Yeah,
No,
James, on this, please. Rob, sorry.
Just to say, I think we from the PwC meeting we had, I think that's the most likely route. As Rob said, we'll get the feedback report tomorrow, so it'll be interesting to see whether that's a sort of general financial governance feedback or whether there's specific issues in there, like structural issues in the system, in which case we expect them to raise the new role. So we'll probably know more by next week's board on that, David, one way or another.
Right, thank you. And I'm conscious this is a public meeting, so I'll try and choose my words carefully here. There's discussion previously mentioned in our hospital management board reports about uncertainty over funding for waiting list initiatives and extra activity we might do as the year progresses. What do we understand the consequences of that? Will we be looking to reduce activity and accept the impact that will have on our waiting lists, or will we do the work and not get paid, or is that something yet to be decided?
No, so the way the contracts work are set up now, David, is, as I say, we've agreed the basis. We've still got to sign them. Is that effectively it becomes a commissioner responsibility to work with the providers to activity manage. So if we are overperforming, and you'll see from the finance report, there's about £1 million worth of activity we're overperforming as at month 2. The commissioners, the ICB, will look to activity manage and work with us. There's a 3-month period in which they will do that. So it's quite possible that they will come back and start those discussions with us. Having said that, it's these dual priorities, isn't it, of hitting our waiting lists and reducing our operational targets. So, but it remains a possibility, and I'll keep everyone abreast if that commences.
Right, thank you. And one last question, if I may, Chair. Is there a point in our discussions where we have to look at deferring some of our capital ambitions for the year in order to save cash?
Absolutely. Part of our cash management process and actions we're taking is looking at prioritising our capital. Obviously, for a significant amount of the projects we've got, they are nationally funded, so that's good. It's for those items that we use our own cash and capital for, that we've got to look to prioritise. And Mike Burns is on behalf of the group is looking at that, and is going to be sharing that with execs.
Okay, Thank you very much. Thanks, Chair. Thanks, Rob, for a very clear report of some difficult situation. Thank you.
And Mike, please.
Thank you. Thanks, Rob. That was really good. And just trying to put your presentation and James's comments together. The level of assurance that we would take from all of this at this point in the cycle. So I was thinking organisational serious-mindedness and determination to address it, absolutely, no issue about that. Level of in-year progress, I think this is the furthest down the track would be an equivalent point in the year, so no issue about that. Systems, HMB, site risk, performance improvement, transformation plans, we've got systems in place. All of that said, I think my instinctive take on where we've got to at this point in the year is I would take moderate assurance around our ability to deliver a really ambitious plan. And I think that's probably okay, just about at this point of the year. Is that a summary that you would recognise and you would be okay with? Have I missed something in that basic moderate assurance position?
So personally, I think that's spot on, Mike. I think I call out in some of the narrative. I think we're going to have a delivery risk throughout the year, to be honest, because as you've heard, we talk about bed closures and the saving WTEs. They're really hard-won yards, and we do that balancing all the safety aspects and operational realities. So absolutely, I think that moderate assessment is what we'd say.
Yeah.
Just come in there. Yeah, I would agree with that as well, Mike. I think without wanting to sound like a broken record on the issue, the biggest risk for us, I think, is that we're a year or two further down the line of this level and depth of freezes and cuts compared to other organisations. And that's on the basis, again, I would say this, wouldn't I, but on not having the sort of structural issues around the new hospital recognised. We've had bigger CIPs for longer, and therefore we are getting to this sort of end point of things that you can do just by freezing, holding posts and positions. So to get us from the position we're into a better one is really around pushing hard the acceleration of the last integration around corporate services and opportunities between sites. And some of that's recognised in the plan, but it's very small. It's probably 1.5 million or so on the corporate stuff. But if we can do more than that this year, then that's one area that is within our gift. And I think also the sort of broad green heart and chest axis, now that the heart and chest will be coming in to the governance arrangements, is an untapped area that, again, might add an amount, not a huge amount, but an amount to the plan. So we've just got to keep driving at the closing of the gap. But I would agree, I don't think we're better than moderate at the moment.
Thank you. Really helpful. Thank you.
Thank you. And a sense from the site reports and so on, clearly we're working with this, Rob, with this 1 month lag. We're now into July and we're talking about May, in the sense that we've made some significant steps in June. Without wanting to build up expectations about that. Would we expect to see a step change on some of that in the June report?
Well, certainly in the June report, we enacted the bank rate change in June. That had a full year effect of circa, I think it was 2.5 million. So that will all start playing into position from June, and we know that's happened and it's been relatively successful. The bed reductions, as we said, will also all feature in June. So there will be some things there definitely that we would expect to see an improvement in. As we said earlier, it's when you look at it from a sort of headcount perspective, that the lag of not taking everything out on day one is what it's going to do for us. But yeah, we should see an improvement from that perspective.
Okay. So I think in the way, Rob, that you set it out now, we've got a structure that enables us, a reporting structure that enables us to monitor progress on headcount and other aspects of progress. So I think as a committee and as a board, we're better able to track where we're at and understand variances, and then for you to describe to us the mitigations that are being taken to manage the adverse variances. I think that's good. I think we've been able to do some things that we haven't been able to do in previous years, and we've done others that we have done, but we've done them earlier this time. So that they point in the right direction. with my unremarkable prediction is we are not going to find it easy to get ahead of the game on all of this. It's still going to be a charge for the line come March. We're not going to be ahead of the game and coasting to the end of the year. It's going to be a battle every single day and every week to get to the line, and it is a relentless focus. And for executives in this meeting and the people who report to you and the people who report to the people who report to you and so on through the organisation, this is going to feel attritional for us to get to where we need to get to, and we should recognise that. But look, as we discussed previously, we're in a situation now where consideration by others above and around in the system is being given to how quickly we can progress some of the collaboration and integration plans, which are with other trusts, which are essential, absolutely essential for the clinical and financial sustainability of our adult acute and specialist system. It has to be done, and we must not get ourselves into a situation where coming up short on our own things becomes the reason that we can't move forward with all of that. So this relentless focus and action is essential, not only for short-term delivery, but to give us the permission to do the medium to longer term work that's needed. James?
Yeah, I think it would be useful over the next couple of months as we discuss this as well, to come back to. Now, this is not a sort of a statement that says, well, we didn't agree the plan. The plan is the plan. But I think it's always helpful to come back to, what did we agree as a board that our original plan was within the art of the possible? When there was stretch one, we added in bed closures and urgent care that we'd previously said we wouldn't tackle because of failure to support that at a sort of system perspective previously. But then we got a risk share and we got some support from the ICB and turnaround. And then we got stretch two, didn't we, which was just drops on every organisation on the last day. I suspect when we look at things now, we can at least satisfy ourselves that the things we said we could do originally in the original 75 million, circa 75 million CIP, if you look to where we are now, we'd be on track to deliver that. If you look at then the stretch one, where we took a considered view as a board around urgent care and the risks around that and the risk share, we would be getting fairly good assurance now that things are starting to move in the right direction in a way they hadn't before around bed closures and reduction in cost and WTs in relation to that. On the stretch two, which was the sort of drop from the air stuff, that's the area of risk that we've still got. It doesn't get us out of the fact we need to deliver the full plan, but I think as we externally report, constantly referring back to it in that way of the things we had certainty of, the things we took on as a board, but they were risky, but we felt we could deliver them. And then the sort of, there's no plan for this, but here's your equal share, is quite an important thing to keep coming back to when we look at it, because I think it's important that we're able to articulate that the things we had in our plans we are doing and are delivering, because it certainly, that's how it looks to me.
Okay, thank you. It's a very good last word for the meeting. I've not been notified of any other business. I've overrun. I apologise to everybody for that. I can't give you that 25 minutes back. We'll put more consideration next month into matching the breadth and depth of the agenda as illustrated in our meeting today with the time that's allocated for it. So, but good discussions. Yeah.
Sorry, I just wanted to say to execs on the call, we're going straight into now another meeting at 12. By show of hands, is there anybody who couldn't manage a 15-minute break first and start at 15:15, given we've been on this for a bit? People might just want to take 15 minutes. Is there anyone who can't do that? If you shout now. No, if everyone could do that, can we start at 12:15 then instead of 12 o'clock? Is that all right? Lovely, thank you. Sorry, Dave.
So I didn't give them a lot of choice actually in the way you framed that.
No.
Okay.
That was intentional.
Thank you very much. Meeting closed.
Thank you.
Thank you.
Thank you.